the only common denominator is that at that time, all of our patients had stopped testing positive for any form of heroin, and they were only testing positive for fentanyl. So in the Baltimore area, we'd had a full replacement of heroin with fentanyl. And so that was, it really has been a journey since that point.
Right.
And it has felt like we're constantly catching up, right? And I agree with you that the tried and true practices of how we had treated heroin do not generally, or don't immediately generalize over onto how we would treat fentanyl exposure.
That's right.
And so we've actually done a lot of work trying to understand the medical fentanyl field to inform how we would, what patterns we're seeing in our patients now and how we might best treat them as well.
Well, welcome to Azar Lab podcast. It's super exciting to have you here. I've been doing addiction medicine research for about 10 years now. And I feel like ever since I started going to conferences, people would inevitably say, oh, you got to meet Kelly Dunn. Have you met Kelly Dunn? She's amazing. And the answer was always no. So, and I think we missed each other a few times pretty closely. So I think it's just such a pleasure to finally meet you. And I'm so glad that you're here in Vancouver. And I'm a big fan of your research. So I was hoping we can take some time, talk about some of the work you do. In terms of an introduction, would you mind going ahead and giving us an introduction in terms of a little bit about your background and the work that you do?
Sure, yeah. So thank you for having me and for those kind words. I have been in the field for about 25 years or so. I was interested in the field. I was actually motivated by experiences that my friends had when I was in high school, becoming addicted to OxyContin and then just kind of wanting to intervene on that. Yeah. And so it's really kind of propelled me forward, which I think is really consistent with a lot of people in our field who are very mission driven by, addiction and wanting to help it. My background and training, I trained in preclinical science first for many years and then moved over into human clinical science and then did a postdoc at Johns Hopkins University and stayed there for about 15 years and really developed my skills in clinical trials and trying to understand, really kind of intersecting with business as well and trying to understand what drives decision-making in terms of business and the outer healthcare system to help incorporate different interventions into their treatment portfolios. And then a couple of years ago, the University of Maryland created a research institute on addictions, and I moved over to direct that. And so that's kind of the new venture right now. And the goal is to really bridge preclinical animal science and human science to really inform change. And we're really, our mission, our logo, I guess, is from discovery to recovery. So we're really trying to focus on, I wasn't involved in creating it, but I think it's really clever. And it's really focused on understanding what is happening with patients in real time and then back translating that into the lab to try to think through new innovations. Yes.
I mean, it's so important. I mean, I feel like when researchers do research in isolation without input from people who treat the patients, the research may be really interesting and exciting, but may not have direct applications to patient care. So I think doing it sort of where you work very closely with clinician scientists, basic science researchers, I think that's where you get the sort of most applicable science that can be used to treat patients. So you started your addiction research journey about 15 years ago, did you say? Or
about 20 years ago. Yeah.
So this is pre-fentanyl.
Yes.
Yeah. Which is really interesting for me because I started practicing addiction medicine just a couple years before fentanyl came to British Columbia, came to Vancouver. So we started to see fentanyl here in about 2012. So as a clinician, it was really interesting for me to see how things shifted, how we used to treat patients, how we tried to use the same tools that we had in the heroin era to treat patients who were using fentanyl, and how we very quickly found ourselves in an evidence void where our treatments became less and less and less effective. What was your observation from a researcher around the time that fentanyl was coming? Or I guess it was a little bit later in the US than Canada when fentanyl arrived.
Yeah. So it's a great question. I have been withdrawing people off of opioids for about 20 years and had a lot of experience treating people with buprenorphine, which is Suboxone, which requires a kind of delicate technique to get people onto the medication, and had been very successful with that. I inducted hundreds of people onto that medication. In 2019, all of a sudden, we couldn't do that anymore.
That's right.
Yeah. And so we had, person after person after person come in that we were trying to induct onto this medication in the standard ways that we were causing severe extreme withdrawal in these individuals. And so the only common denominator is that at that time, all of our patients had stopped testing positive for any form of heroin, and they were only testing positive for fentanyl. So in the Baltimore area, we'd had a full replacement of heroin with fentanyl. And so that was, it really has been a journey since that point.
Right.
And it has felt like we're constantly catching up, right? And I agree with you that the tried and true practices of how we had treated heroin do not generally, or don't immediately generalize over onto how we would treat fentanyl exposure.
That's right.
And so we've actually done a lot of work trying to understand the medical fentanyl field to inform how we would, what patterns we're seeing in our patients now and how we might best treat them as well.
I see. The medical fentanyl. Yeah, so that's interesting. And buprenorphine, and sort of before we get into the things that you're seeing now and so the parallels that you're deriving from the medical patients who are treated with medical fentanyl, going quickly back to the buprenorphine inductions that you were doing previously. So now this is going to get pretty technical, and a lot of people who listen to this podcast come from a research medical background, but not everybody. So we'll just try to break it down to sort of as understandable language as we can. But so I suspect you were using the traditional approach of waiting for someone to go into withdrawal and then starting them on buprenorphine back in the heroin era. Is that?
Yes. Yep.
Essentially. Since you mentioned withdrawal and precipitated withdrawal, do you want to talk a little bit about what that was like when you first started seeing patients go into precipitated withdrawal?
Sure. Yeah. So historically, we would ask people to come in some form of acute withdrawal, which we could measure on a scale, and they would have to reach a certain threshold. And then we would give them their first dose, and we would observe them for an hour, and then we'd give them a full dose after that. And so the whole process was maybe 2 hours. And I had done that so many times so successfully that I actually started to think this is not really necessary. We're making people wait several hours to get dosed, and I don't know that we need to anymore. All of a sudden, we had people come in, and we gave them that first dose, and whereas they had shown some levels of acute withdrawal, now they were kind of off the charts with withdrawal. And we had I never had that happen. And the first person that did that, we thought, there must have been a misunderstanding about when they just recently used, or there must be some interaction happening that we didn't anticipate. And then the next person came in, and that person we actually had to walk over to the emergency department. And then the third person came in, and we had a similar experience, not as severe, and we thought, okay, we have to stop. Something's wrong. The experience of precipitated withdrawal is it's similar to somebody receiving Narcan in that they experience many of the symptoms all at once and kind of at the extreme level. And for the person, it's agonizing.
It's agonizing.
And, yeah. And our patients, what we've since learned is that many people feel that they've developed an allergy to the medication, which is really scary to us because it means that they are probably unwilling to take it again in the future.
Yes. Oh, I hear that. I mean, once somebody has experienced precipitated opioid withdrawal from buprenorphine, chances of convincing them to try it again are very low. They just don't want to experience that, go through that experience again. Yeah. So let's fast forward now. Like, okay, so precipitated withdrawal became an issue, and we didn't really necessarily know what was going on. I know from our side, we started doing a lot of work with low dose inductions, trying to figure out sort of new or interesting ways of getting people onto buprenorphine. But from your perspective, can you tell us a little bit about the research that led you to do?
Yeah, so we were in the middle of studies that were depending on people being on buprenorphine. And so we did the same. We understood that there was a protocol to transition people from long-acting opioids onto buprenorphine, and so which is the low-dose induction protocol. And so we started to apply that as well, and just kind of iteratively understand the parameters of how we could do that. And now we're pretty good at it, but it takes 3 days.
Which protocol do you guys use now?
So we use, I guess, it's probably, I can't remember the name of it, but we've kind of created our own hybrid protocol. Yeah. And so, but we start with very low dosing, 0.5 milligrams oral dosing or sublingual dosing, and then we kind of scale them up within a day. But what we try to do is front load them for a couple days with opioid agonists. So in our studies, we can do hydromorphone dosing for a few days, and we've kind of come to recognize the period of time that it may take to what we're calling anecdotally kind of a washout of fentanyl, which is around 72 hours. And then after that, the buprenorphine induction is much easier. But what it's done is it's really led to work just trying to understand what fentanyl is doing and how it's different from heroin and other opioids to be able to inform how we might best treat our patients. And we've also started to shift over and again to having hydromorphone dosing, which we can do in a research trial to help stabilize people who are in our various different trials as they kind of flush the fentanyl out of their system.
Right, I see. So that's interesting. So patients would come in, you would rotate them onto hydromorphone, wait for fentanyl to wash out, and then do the rotation. So there's a couple of things that are interesting there for me. One is to get a sense of the hydromorphone dosing that you guys use to meet their opioid requirements. Do you have a sense of that?
Yeah. So we had to do a bunch of iterative manipulations to try to figure that out. What we've landed on recently is 120 milligrams a day. So we do 20 milligrams every 4 hours, oral dosing at 24 hours. And that seems to work really well. We had done different variations of that where we had lower doses of hydromorphone or we had longer intervals. And we found that there were more kind of ups and downs for people that were really difficult to manage. So a 4-hour dosing protocol seems to work very well. We specifically have chosen hydromorphone in part because of the trials in Canada that showed that it could be kind of similar in equivalency to heroin. And also because it's less prone to metabolic variations and other opioids like OxyContin.
Yes. Yeah, as well as the morphine. Yeah, that's interesting. I mean, there's a lot of parallels in terms of the way we evolved our protocols as well. We found that the most important factor for success in low-dose inductions was meeting a patient's opioid requirements. And do you continue the hydromorphone when you start buprenorphine?
No. So you don't? Yeah.
Oh, interesting.
We do a little bit for breakthrough pain. But we try to do the buprenorphine all in one day. So we do a 2-day washout or 2 or 3 day washout with hydromorphone and then buprenorphine. And then once they're on buprenorphine, we can maintain them on buprenorphine.
Right. So during that 24 hours while you're increasing the dose of buprenorphine, presumably they're experiencing some level of withdrawal?
They experience a little. And so we have breakthrough medications. So we'll do clonidine, and we have a medication, methocarbamol, that we use a lot for restless legs. It works really well. And some other kind of focused, mechanistically informed medications.
Right. So supportive measures.
Yes.
But no more opioids.
Right. Yeah.
Interesting.
And the goal of that is we really wanted to develop a model that could map onto a clinical care model. It's difficult because hydromorphone isn't readily available, but it could be available in a hospital setting. And we knew that providers and patients would be really unhappy with a protocol that requires several days for buprenorphine induction. And so we wanted to try to condense it all into one day if we could.
Oh, interesting. Okay. Tell me a little bit about what you learned about the differences between fentanyl and heroin or hydromorphone mechanistically. Why is it easier to transition someone from hydromorphone to buprenorphine as opposed to fentanyl to buprenorphine?
Yeah. So we really dug into the medical literature, looking back at fentanyl when it was first developed back in the 60s and 70s, and trying to understand the components of fentanyl that make it different. Came to learn that it was designed prospectively to be very lipophilic, so it crosses the blood-brain barrier very quickly. Yeah. And then it moves back into the body and is stored in the muscle and the fat cells for extended periods of time, and that it accumulates there and can show kind of sensitization, meaning that as people have more accumulation, it takes a smaller dose to produce an opioid effect. We also know that when patients enter treatment, a colleague of mine, Andrew Hune, did a study on people who were just entering treatment with fentanyl exposure in a residential treatment program, measured their urine on a daily basis just to try to understand kind of the clearance of fentanyl and its metabolite norfentanyl, and found that it took between 7 to 14 days for those individuals to be completely clear of those drugs. So we think, and there's a third phenomenon called secondary peaking that you see in the medical literature related to fentanyl. And this was kind of established back in the 70s when they were really looking at it as a medication to give during surgery. And they had a few patients where they would receive fentanyl and then wake up from their surgery and they would be fine and coherent. And then a few hours later, they would all of a sudden go into respiratory depression that was reversible with the, Narcan antagonist, and suggesting that it was an opioid-related effect. And so my kind of big picture thinking, and this is a bit speculative because it hasn't been really studied in the illicitly manufactured fentanyl arena, but my big picture thought is that our patients are receiving super therapeutic, much higher doses of fentanyl than we've ever studied in this literature, that it's being stored peripherally for extended periods of time, and that they may have this secondary peaking phenomenon where it's kind of coming back out in bolus doses. And it suggests, the data from animal studies suggests that the sequestration of this drug in the body is clinically meaningful, can interact with other opioids and antagonists. And so my personal hypothesis is that that's one of the things contributing to the challenge with buprenorphine induction. I don't know that that's true. We haven't been able to study that. There's probably other features as well. And we know, I think there's a controversy in our field about how much of that has to do with the fentanyl producing a very deep physical dependence and buprenorphine not meeting that need. But I think that it has to do with the peripheral sequestration.
Oh, okay. And I'm trying to understand the mechanism of how it would be released in a bolus. Do you have a sense of that?
So the data from fentanyl, from the medicinal literature, just suggests that it is essentially, it's sequestered in the fat as kind of the last stage, and that it's released back into the plasma. And so I guess I don't know the mechanism that it would happen. Maybe it's been uncovered and I'm not aware of it.
Okay.
But there's pretty clear pharmacokinetic data from humans that that's what has happened. Not in everybody, but in large
that it'll be released
back into the plasma.
I wonder, do you have a sense of objective opioid tolerances of your patients in where you guys practice? Like how much sort of microgram equivalents a patient might be using?
It's difficult to know. Yeah, we do have quantitative levels of fentanyl exposure at the time that they come in, which can be very high, but it's variable. It's highly variable as well.
Yeah.
But it's difficult for people to give us an accurate determination.
Right. For quantitative exposure, do you mean you test their substance when they use it, or
we test their urine when
their urine? Got you. Yeah, something super interesting that we discovered with our patient population was, so we created a protocol, again, out of need to treat withdrawal. Again, going from this pre-fentanyl era, good old heroin days, patient would come in, 10 to 20 milligrams of oral morphine solution every 2, 3, 4 hours, and they're fine. They're out of withdrawal. Very quickly, that was no longer effective. The morphine doses went up and up and up. We switched to hydromorphone, 5 times more potent. Doses went up and up and up. We switched from oral to IV hydromorphone. Still, we had a segment of our population that remained in withdrawal. So we decided to use IV fentanyl to treat patients in withdrawal, to get them out of withdrawal in hospital in order for them to meet their medical surgical needs, right? So this was not like an opioid replacement program. It was solely to ensure that the patient receives life-saving medical surgical intervention, and as opposed to them leaving hospital to use. So we created this protocol where we would give them IV fentanyl every 5 minutes, and we chose 5 minutes because fentanyl takes about 4 minutes to get to the CNS from IV. And then we'd do a sedation score. And then we would keep repeating this until they met our sedation goals or they told us they're out of withdrawal and comfortable. So I invite you to take a guess. What do you think sort of average fentanyl tolerances were, or what a high one might be?
Oh, I don't know. Yeah. I'm interested to hear.
Yeah. So it was difficult. Okay. And to put this into context for people who may not know, if a patient comes into the emergency department, opioid naive, they've broken a leg, we want to give them some fentanyl to get them out of pain. You might give 50 mics of IV fentanyl. Maybe repeated now they've had 100 mics. You don't go beyond that. On average, it was difficult to get somebody out of withdrawal under 5,000 mics.
Wow. IV
fentanyl. The highest amount of IV fentanyl that we've given is 22,000 mics to get somebody out of withdrawal. That is staggering. That, and I think that number had never been described before in the literature. But that sort of told us a couple of interesting things. One is from a neurobiological receptor level perspective, something different might be going on when you have such high doses of fentanyl as opposed to the opioid naive patient who may receive fentanyl for therapeutic reasons. The other is, maybe we have to rethink how we treat withdrawal in this population, because maybe they need much higher doses of opioids than we were expecting. Maybe it's safe to treat them with higher doses of opioids to get them out of withdrawal. The third thing we learned, which was really interesting, is that, maybe the doses of agonist therapies, such as methadone, that we were using in the heroin era are not going to be adequate to meet these patients' opioid requirements. Like back in the heroin era, 50 to about 100 milligrams of methadone was typically enough, maybe 150. So I'm doing a lot of talking, but I'll finish this off. One of the interesting things we did a trial where patients would come in an outpatient clinic. We'd give them IV fentanyl. As a measure of opioid tolerance until they're comfortable. And then we'd convert the total amount of fentanyl they received into a starting dose of methadone. Because now we're just doing an opioid rotation similar to when we treat pain patients, we want to rotate them from hydromorphone to the methadone for pain program. And it was not unusual to start patients on 200 milligrams of methadone as a starting dose. So what that taught us was that we're taking way too long to titrate people onto methadone, and they're typically not getting to adequate doses of methadone. We just finished the trial. We haven't published yet, but I think that was really interesting for me, just to think about the neurobiology of opioid tolerance and what it might look like in the face of such staggering high doses of fentanyl.
Yeah. I think that sounds really compelling. The concept of being able to test and understand somebody's fentanyl dependence or tolerance, and then kind of quickly go. Because I know that there's discussion in the field about, can we more quickly move to high dose methadone and to speed up that induction process, because we know we lose so many people in that first 3 days.
It's at this point, thank you for bringing that up. I think it's next to impossible to use heroin era protocols to titrate somebody to an adequate dose of methadone. It'll take weeks to months to get there. And I feel like we can no longer, this is why I'm so appreciative of the work that people like you do, because we can no longer rely on the evidence that we used in the heroin era. Right now, it's been, well over 10 years that we've had fentanyl. We just have to now use protocols that are relevant to our current patient population. But it's a shift in mentality. And I think it's scary for a lot of clinicians to think about that shift. It's like, really, are we going to start people on 200 milligrams of methadone as a starting dose? But I think that's why it's so important to have these tools where we can actually objectively measure tolerance. But this is Canada. It's much easier for us to do these studies as opposed to, I think you guys, and this might be something interesting to talk about as well, in the US. Like, can you imagine a clinician pushing IV fentanyl to get somebody out of withdrawal? Maybe not.
I think that would be, we could probably do it in the context of a research study, but I do agree. I think that there would be a lot of challenges to that. But I am in full agreement with you. And when I give talks on this topic, I often try to make that point that fentanyl is a fundamentally different opioid than heroin, and that we need to reconceptualize and think through new protocols, and that we can't just generalize over. And I keep thinking about a patient described this to me once as heroin felt like a hug from an old friend, and fentanyl just feels like kind of hitting up against a wall. And I just think that that's such a nice way of kind of conceptualizing it. It's just fundamentally different for people.
Oh, it is. Yeah, absolutely. And I remember my patients who used, it's just changed use dramatically, who use heroin, they might use 1, 2, 3 times a day. And they would experience that euphoric effect, like you're describing, that hug. Because of the half-life, time to onset, etc., of potency of fentanyl, patients are now needing to use like every hour. And we saw this shift. I'm not sure, I'd be interested to see if you guys have seen this as well, away from injection use to smoking. And a big part of that is it just was no longer possible to inject yourself every hour. People were losing their veins. So they switched to smoking. But yeah, fundamentally different. And then it's interesting to think about, okay, what about on a receptor level, on a cellular level? How is fentanyl different? So 2 questions. One, did you guys see that change, that shift to smoking from injection use?
We're just starting to see it on the East Coast. The West Coast has seen it.
Mm-hmm. Yeah. Well, let's talk a little bit about cellular biology. Do you have a sense of the differences or neurobiological differences from fentanyl to exposure to heroin exposure?
So a lot of the focus that I have had is really focused on kind of the peripheral, the lipophilicity and things like that. Aside from that, I think I think that there's a lot. I think we have a lot to learn.
Yeah.
I'm interested in your thoughts on that.
Yeah. Fentanyl, this concept of beta-arrestin pathway versus G-protein pathway, and the impact from a side effect profile, but also from a neurobiological perspective. Some opioids being more one pathway than the other. I personally think that is extremely relevant when it comes to thinking about molecules like buprenorphine, even naloxone. And that sort of has helped me guide my understanding of like the mechanisms that might be involved in precipitated withdrawal, etc. Because precipitated withdrawal is interesting because, like you said, it can be such a barrier to treatment. Do you have a sense of like the mechanism of precipitated withdrawal, like how that comes about?
I don't. So I think that there's a lot of controversy and discussion.
There is. That's why I'm bringing it up. There's a lot of controversy. Yeah.
I think there's been there's in the States, at least, there's discussion about whether it's legitimate and whether there is a precipitated withdrawal, or if it's just uncontrolled anxiety.
Oh, geez.
There's also, which I don't agree with that perspective. I think that it probably is somewhere between, in my view, the peripheral contribution and the kind of stores of fentanyl, as well as the deeper dependence produced by fentanyl. But I don't honestly know. I mean, I think, part of the challenge is it's hard, it was hard to really identify that this is what was happening, that it was this meaningful interaction or some kind of, that it was very specific to fentanyl exposure. Yeah. And then it feels like we're always just trying to figure it out in real time, right?
No, I agree. And do you want to talk a little bit about macrodosing?
Sure. So macrodosing is the concept or the approach of, I guess it's from the perspective that the precipitated withdrawal has to do with not meeting the opioid deficit.
That's right.
And then giving a very large macrodose all at once. And we have a protocol actually kind of comparing macrodosing and microdosing, low dose dosing, I guess, relative to...
It's a study?
Yes.
Yeah, beautiful. Love it.
And we're also adding Naloxone-Facilitated Induction as well to try to compare the 3 of them.
Yes.
I'll be honest, my experience with low dose induction and the buprenorphine precipitated withdrawal that we saw kind of in the early stages has always made me very worried to go to macrodosing. So we haven't started that part of it yet. And it's actually being run, Cecilia Bergeria at the Collar Institute is running that. But have you tried that? Have you tried macrodosing?
We've been doing it since when I started practicing.
Yeah.
We actually used to call it treatment dose inductions because our induction dose was the treatment dose. So the concept for us is if a patient is already in withdrawal, then there's no chance they're going to cause precipitated withdrawal. They're already in withdrawal. So why not just give them a large dose of buprenorphine? Like, what are you afraid of? They're opioid tolerant because they're using fentanyl. They're already in withdrawal. So what bad thing can happen, right? And I think there is a misconception about macro or high dose inductions, in that some people might believe that you can just give anybody a large dose of buprenorphine and they're good to go. That's not true. They have to be in withdrawal. So you have to wait for them to be in withdrawal before you give them the macro dose. But if you're already in withdrawal, you're in withdrawal. Like, you're not going to get more withdrawal if you're already in withdrawal. So now the D'Onofrio study, you're probably aware of, which was interesting because they demonstrated, Andrew Herring, one of my close friends, was involved with that as well. Do you know Andrew? You must. Everybody knows Andrew. So they demonstrated that, cows of age with like 1 or 2 objective signs, I can't remember if it was 1 or 2 objective signs, you can just go ahead and start patients on a macrodose of buprenorphine. And for them, I think it's like 1,400 patients. The study that I'm thinking of, risk of precipitated withdrawal was less than 1%. But patients are already in withdrawal. Now, from what I remember, many of those patients were pre-dosed with adjuncts. like lorazepam, etc. So maybe their COW scores were a little bit higher than my COW score. But so if they're in withdrawal, no problem. Full dose of buprenorphine, they're good to go. It's actually fun to watch. The patient get rescued pretty quickly.
So you've done this in people who are fentanyl exposed?
Oh yeah.
Okay.
Everybody's fentanyl exposed. We don't have non-fentanyl exposed patients anymore.
Okay.
Yeah, very rare.
So the question that I have, and where I've always struggled with this, is that we know that low dosing of buprenorphine can still precipitate. People are kind of experiencing both a precipitated and a spontaneous withdrawal at the same time, right? And so, or at least that's what we've observed. So if we have people in the early days of transitioning them from fentanyl to buprenorphine, we would give them low doses, but they would still have kind of breakthrough spontaneous withdrawal. And we would wait for them to meet a withdrawal threshold before we did it. So they were in acute withdrawal, and we were still worsening their withdrawal with lower doses. And so where I've always been worried myself in doing this is that it's going to be so difficult to rescue if the higher dose does in fact just produce a more
very good point you brought up. And this is something we see clinically. We saw very early on when we were developing our low dose induction protocols. Critical point that you raised is when a patient starts to develop withdrawal during a low dose induction, it's super important, and I think you've written about this as well, if I'm not mistaken. It's super important to delineate, is this opioid deficiency withdrawal or is this precipitated opioid withdrawal, right? From my experience, when a patient is being low dose induced or initiated, I've heard we can't use induced anymore, low dose initiated, and they start to experience withdrawal, that might be called precipitated withdrawal. But when I go back and look at that patient and I look at what doses of full agonists they were being treated with for withdrawal management during the low dose induction, it invariably becomes clear that no, this was not a precipitated opioid withdrawal. This was a gradual onset of opioid deficiency withdrawal because we were not meeting their opioid requirements while we were low dose inducing them. And I think it speaks to the need to have a new definition of precipitated opioid withdrawal. Like, I think the one that's more typically accepted, you know more about this than I do, is like 5-point increase on the COW scale. If that happens, you have precipitated opioid withdrawal. To me, that's not adequate because that doesn't actually distinguish between opioid deficiency withdrawal and precipitated opioid withdrawal. I think what I would like to see as a definition is one that takes magnitude into account, how much increase above baseline, and clinically significant withdrawal. Because using that definition, a COWS of 0 to a COWS of 5 could be considered precipitated opioid withdrawal. I likely have a COWS of 5 right now. I'm not in withdrawal, right? And I think in addition to magnitude, we need a time factor and we need to have an instigating factor. So exposure to a substance that can cause precipitated withdrawal, a time from that exposure to the onset of symptoms, and a total magnitude of symptoms, as well as clinically significant symptoms. So from my experience using our protocols, if a patient's opioid requirements are met while they're being low dose induced, it's extremely rare for them to experience withdrawal. And it's very, very, very rare for them to develop precipitated opioid withdrawal. I think in my mind, that's how I distinguish the two. Sorry, but I think
go back to macrodosing.
Yeah. So macrodosing. So for macrodosing, if a patient is already in withdrawal, they're already in withdrawal. The receptor level changes that are responsible for withdrawal have already occurred. So now you can just give them a whack dose. You can give them a large dose. What are you worried about at this point? They're already in withdrawal. So now you can rescue them from the withdrawal. You're certainly not worried about like respiratory depression with buprenorphine if they're tolerant to opioids. So in my mind, it was a no-brainer when we started doing this. Again, we called it treatment dose inductions because we wanted their induction dose to be their treatment dose. Get a dose and leave. Like this business of slowly titrating people up didn't make any sense to me. But you also mentioned, I wanted to go back to this. naloxone-facilitated inductions. That's an interesting world, and I want to talk about that as well. Do you want to tell us a little bit about what that is and how you guys are studying it?
Sure. So the idea behind that, again, kind of in the early days, we had 3 different options, and we were thinking through how we could induct people initiate people onto buprenorphine. And we started to talk to people that were involved in ED or emergency department based studies that were finding that they were not seeing buprenorphine precipitated withdrawal when they started patients. And we wondered how much of that was related to the patients being brought to the emergency department because of an overdose and having had recent naloxone exposure. And so started thinking through, is this something that we could do? Could we actually use naloxone administration as a way to remove all the fentanyl from the receptors, or most of it, right? To be able to kind of quickly get the person onto a loading dose of buprenorphine. And then we saw a few case reports come out about that people were reporting that. And then there's a team in Boulder that started to do that. And so we worked with them to understand, how they might do it. And then have the goal is to actually have a comparison between the 3 different strategies to see if they're relatively equivalent or if one might work better than the other.
David, what's his last name? I presented with him at ASAM. David from Hopkins. Oh, shoot. He was doing a trial on
Walensky.
Yeah,
that's
Dave
right.
Walensky.
Good call. Yeah. You know David. Yeah. So we presented together on the panel at ASAM. So he was describing, was that essentially, so patients come in, they use fentanyl. I think in his study, they were being rotated onto hydromorphone. The next day, they would get a full dose of naloxone, precipitated opioid withdrawal, and then rescued with buprenorphine. Yeah. So that's interesting for me, and I have a hard time wrapping my head around that, not mechanistically, but it's a lot for a patient to go through. I feel like, we're talking about not a little bit of withdrawal, but like House of 30 or whatever. One of the things we did, you haven't heard about our Sinai protocol, symptom-dependent naloxone induction?
No. I've read a little bit online, but
yeah. So I think you might find this interesting. I had a patient in the emergency department. She came in, I was sort of halfway through my shift, and she was using fentanyl. She was not in withdrawal. She came solely to be initiated onto buprenorphine. There was no medical, surgical, or psychiatric reasons for me to admit her to hospital and low dose initiate her. So I was like, okay, let's just wait for you to go into withdrawal and we will macrodose you. We waited and waited. My shift was over. 4 hours had gone by. She was still not at a CAS of 10 or whatever. So she was frustrated. She left. My shift was done, and that was like a treatment failure as far as I was concerned. So the thought that came to mind is like, geez, is there a way that we can control the onset of withdrawal? Instead of waiting for us to go to withdrawal, can we bring withdrawal to us, but in a controlled manner? And through the work of D'Onofrio and Andrew Herring, we now know sort of what the minimal withdrawal is required to macrodose. So we created a protocol where we essentially microdose naloxone based on the pharmacokinetics of naloxone, time to max effect. So what we ended up doing, patient would come in, no withdrawal, they've just used fentanyl. We'd give them microdoses of naloxone IV naloxone every 2 minutes, 0.1 milligrams. Give a dose, wait 2 minutes, do a CAS score. Give a dose, wait 2 minutes, do a CAS score. Once they're at a CAS of 10, rescue with sublingual buprenorphine. And it worked beautifully. And so we're talking about, the fastest we've done is in 10 minutes. With fentanyl use, no withdrawal, CAS of 10, buprenorphine. So it's building on that same concept of high dose inductions. They're in withdrawal. What are you afraid of? Let's just treat them. But it's just a way of controlling the onset of withdrawal to avoid suffering. So why does this person need to go to a CAS of 30? Why can't we control the withdrawal to get them to CAS of 10 and then do what they've done in the macrodosing studies? We just got ethics approval for our study on this. I was using it as a clinical tool up until this point. But I think it's just interesting to see how protocols evolve, because it's sort of everyone builds on the previous one. So I would love to hear your thoughts about that approach.
I think it sounds great. I mean, it's the same general concept.
100%.
The challenge for us is a lot of the work that we do is in an outpatient setting.
Yeah.
And so the intravenous dosing would be very difficult. So we've tried to think through, how can we do this? How can we provide a tool to providers who are in a primary care setting and want to be able to quickly initiate buprenorphine? And so I think that we've got a lot of refinement to do. And there's probably ways that we could give a lower dose of naloxone. And I think what David and Cecilia are finding with this protocol is that the interval after the naloxone is administered needs to be very short, right? So within a minute or 5 minutes, the person has a full loading dose of buprenorphine. But it seems to be a potential tool.
Are you guys using IV naloxone?
No, so we're using intranasal.
Intranasal, that's right.
Yeah,
that's right.
And
that's right.
The patients are self-administering it.
Yeah, that's right. I remember that. That was an interesting point because they're self-administering it. Yeah.
But I think the concept is similar, and I really like it. I think it's really grounded in pharmacology and just provides another tool to be able to kind of quickly help people work through this experience and get them onto the medication.
Yeah, I think so. That this concept of starting it quickly is interesting. I find that as well. Like I don't mind giving people like extended release injection in that context as well, but I always want them to get a loading sublingual dose to, as quickly as possible, increase the serum levels. And I would, what I would love to see is to use IV buprenorphine in this context. I think that would be really cool. Yeah. How are we doing for time?
We're at 2:15 right now, 2:17. So we've got if we push it, 15 minutes. But we should probably try to wrap things up.
Yeah.
I had one question. You mentioned at the top that you got into this because you were watching some of your peers go through the OxyContin crisis of its own. I'm curious if you can tell us a little bit about that experience, add some color to it, so we can understand a little bit what that was like for you, why that drove you into addiction medicine, and then how, without giving away too much, the time frame, and in terms of what your awareness was around the overprescription and all of the stuff that was going on in the back end that we found out later.
Sure, yeah. So I grew up in upstate New York, which is a very rural area. I was in high school when OxyContin was released to the market, and at the time, people in the area called it hillbilly heroin. That was the name for it. Nobody knew that it was. I didn't know what it was. I didn't know it was an opioid. Certainly, we didn't understand the risks associated with it. But it was a time in my life, and I remember this really vividly, that I knew that, the end of high school was coming, and just wondering, where am I going to go with my life, and where are these other people going to go, and are we going to still be friends? Will we know each other? And this was in about 10th grade or so. And by the end of high school, many of those individuals had developed severe dependencies and addictions to OxyContin. And it really fundamentally changed their trajectories and their futures. And that was just very salient to me. And I loved them very deeply. And I really wanted to find ways to help them and kind of get them back on course. And so I was very interested in how drugs work as a result, and went to an undergraduate school where I took a class in psychopharmacology. And then it just all clicked that you could actually engage in this in a scientific, empirical way. And then I've just always kind of moved forward with that interest. And I've been very focused on opioids this whole time, largely because of that experience, because it's difficult and it's complex. But I've seen the development of it. And then I've also seen on the back end when people recover from it, and just how rewarding and wonderful that can be. And so that's really what's driven a lot of it.
And was there someone particularly close to you, and was there ever like a full circle moment where you were helping someone that you knew that went through that, or?
Yeah, so many of the individuals have continued to have lifelong battles with addiction. Some we've lost some of them to fatal overdoses. Many people are in long-term recovery, so they've been on sublingual buprenorphine or now the depot for many years. And I still, I haven't lived in that area really probably for 25 years, but I still am friends with them and still kind of reach out and provide guidance and support and connect them to resources and things. Yeah. So it feels, but I think that that's really representative of the addiction field. And this is something I've thought a lot about in the past few years. And because of this research institute that we have and how much enthusiasm there is in this institute, and it made me realize that, most of the people that work in this space, I think, are very driven by the mission, and maybe they have personal connections or whatever it may be. I don't know what drives it, but they, because there's not a lot, it's not easy to work in this area. And there's a lot of challenges and increasingly more challenges. And yet people just remain so committed to the topic and really wanting to kind of advance the science of it. And so we see that a lot in the Institute, that because of the way that it's been established, we've got a lot of support behind us to be able to advance things. And everyone is coming to us with ideas. And it's like all these individuals that have wanted to engage and develop new areas of work for a while and just haven't had outlets. And now once they have the outlet, it's just incredible the work that they're doing. And yeah, so I think I do feel very strongly committed, but I also kind of feel like we're at this inflection point where there's been enough investment in the field to be able to really understand publicly that this is important, that it can affect anybody.
That's right.
And that we're starting to see changes where there's more industry investment and there's more kind of central public health investment than there has been in the past. And that I think that we're starting to see these scientific discoveries that are going to really, change the way that we can fundamentally transform the way that we are able to treat, which hasn't really been the case for the past few decades.
Yeah.
A little more hope.
Yeah.
Yeah.
Yeah. I mean, I think it's commendable, and it's a nice story. I mean, it's a sad story, but it's also a nice story that like you were able to take that personal connection, that it's something that touched you personally, and to turn that into such amazing work to help other people. So let's maybe finish off talking about the future. Where do you see this field in 10 years?
Well, I think in 10 years, the big goal is to cure addiction. I know that's a big goal, but what I hope happens is that we continue to destigmatize it. I would love to see a scenario where people feel empowered to come in and talk to their providers early in their substance use trajectory, because we often see them when so many things have compiled in their life that they feel that they don't have any other choice, but they have been reluctant to disclose it prior to that. And I think it's much harder to intervene at that point. So I would like for us to move to that, where people feel more empowered to say, I got in over my head, or this has caused problems for me and I need to intervene, and there's not stigma associated with that. I also would love to see more options for treatments available for patients. I talk about this a lot, that if you compare our field to a field like major depression, which I think has a lot of similarities in that they're both chronic and relapsing conditions, and they're very complex medical behavioral disorders. And they both had this very pivotal finding in 1965 that for opioid use in particular, it was the identification of methadone as a treatment. And for major depression, it was the monoamine hypothesis of depression. And since that point in opioid use, we've had 4 medications approved.
That's right.
And in depression, there's over 90. And we have options so that if a medication doesn't work, it's kind of anticipated that you need to go through a couple different options before you find the one that works for you. And we don't have that opportunity in substance use, and in fact, if it doesn't work, there's often a stigma associated with it, right? That you didn't try hard enough. Right. So those are the things that I would like to see happening, and I think that we're moving in that direction. That we're recognizing that we need more options for our patients. And then the final thing is that I would really like to see us move towards, I guess, to have the treatments really reflect what's happening in the real world condition, because a lot of our studies really focus on unitary syndromes, right. But meaning that we do clinical trials for opioid use disorder or cocaine or stimulant use disorder. But in the real world, people are exposed to multiple different things. And so it's not mapping on to what the actual needs are in the clinic. They're still siloed. And so with the Institute, what we're really focused on is understanding what's happening in the patient population in the real world, which is that they are exposed to many things and that there's commonalities across those. Things like craving are present for all of the use disorders. And then we want to map that back and back translate that into our animal and human studies to be able to really genuinely inform the practice of addiction medicine so that we can help patients more quickly.
Yeah, no, that's beautiful. I like that. And I think, couldn't agree more. And I'm also hopeful that we can start to employ like a biopsychosocial approach as well, like working hard on the biological perspective, the pharmacology. I think addressing the psychosocial component, I think, is important as well. We didn't talk about dreams. We were going to talk about dream engineering and substance using dreams, etc. But we were like rapidly running out of time. So I will let Adam Horowitz, who's one of our colleagues, who has developed this dream engineering program, and we'll let him talk about it on the panel. Thank you so much for joining us today. Like, it's been such a pleasure having you here. I would love to collaborate with you in the future as well. I love your research. Thank you for your time.
Thank you. Yeah, It's been wonderful talking with you.
Yeah, thanks. It's been fun.